Hi folks, today we are going to talk about the digestive system. Here are all of our objectives for this part of the class, this lecture. If you're comfortable with all of these, you should do very nicely on the quiz. So the digestive system is essentially one great big long tube that runs the length of the body from the mouth to the anus. And that is the only time you want to hear those three words in a sentence, otherwise you're talking about some kind of weird human centipede nonsense. Other names for the digestive system, you've probably heard of the gastrointestinal tract or GI tract, and you may have heard of the alimentary canal. This is a little more old school. But occasionally you'll run into a nurse or a doctor that uses that term. The digestive system, like I said, is a big tube that's full of different outpouches. Some parts of the tube are very big, some parts of the tube are very small, some parts are long, some parts are short. But essentially that's all your digestive system is. There are three main functions of the digestive system. The first one is obviously digestion. This is taking the food that you've consumed and then breaking it down into its very, very small components. So our three micronutrients are protein, fat, and carbohydrates. Protein gets broken down into amino acids, which are the tiny little building blocks of proteins. Fat gets broken down into fatty acids, and carbohydrates get broken down into simple sugars. And then once all of these nutrients are broken down into their simplest form, they are ready to be absorbed into the bloodstream to then go to all of your cells that need these various nutrients. Last function of the digestive system is elimination, obviously getting rid of any waste material that cannot be digested and used by the body. So the organs of the digestive system, the main ones we have here, the mouth and the pharynx, the esophagus, the stomach, and your intestines. So think for a little bit about which of these functions, digestion, absorption, and elimination, take place in which of these organs. So digestion starts in the mouth. We also see a little bit of it in the stomach. We see a lot of it in the small intestine. Absorption is mostly the small intestine. We see a little of it in the large intestine. Actually, we see a little bit of it in the stomach too. Alcohol tends to be absorbed through the stomach. This is why you get sloshed a little faster if you have not had anything to eat. Not that any of you would know that, I'm sure. And then elimination occurs in the large intestine. So digestion breaks down food so that it's small enough, it's in its little nutrients that can be absorbed by the cells from the blood. And digestion occurs two ways, by mechanical means and by chemical means. By mechanical means, we're talking about things like chewing up your food, physically breaking down your food. Your stomach churns up your food and helps to break it down as well. Chemical means would be stuff like the hydrochloric acid in your stomach, enzymes that the pancreas makes. That's an example of chemical digestion. This occurs in your digestive tract. Obviously, food is moved through your digestive tract via peristalsis, which are these kind of wave-like contractions of muscle. Imagine, if you will, like a snake swallowing something whole. That's a good example of peristalsis. Digestion begins in the mouth. We see both chemical and mechanical digestion in the mouth. Mechanical digestion. Mastication, be careful with your pronunciation, is the medical term for chewing. This is how you break up your food into smaller pieces. In addition to that, there is an enzyme in your saliva called amylase. Amylase breaks down carbs. So it starts working on any starches or sugars that are in your food while you're chewing it up. Food that has been completely chewed up, mixed with saliva, is ready to be swallowed, is called a bolus of food. That's what we mean by that moistened food there. So when you swallow, that food will go into your pharynx, which is, if you remember from the respiratory system, the area right behind your nose and mouth. From the pharynx down into the esophagus, from the esophagus then into the stomach. Looking at stuff a little more detail in your mouth, your teeth are made of enamel. This is the hardest substance that you have in your body. When you get buildup of food particles on your teeth, that's called plaque, and that houses bacteria. That's how bacteria build up and grow and live on your teeth. And as those bacteria hang out on your teeth and eat the little food particles on your teeth, they produce acid as a byproduct. And that acid starts to eat its way through the enamel until we get down into the dentin, which is the very sensitive layer of the tooth. There's a nerve root here. This is where you get the pain of a toothache if you have a really bad cavity that goes down into that dentin. Now, obviously, you get buildup of plaque and you get buildup of bacteria on your teeth if you're not taking care of your teeth or brushing your teeth. Please brush your teeth. But you also see issues with tooth decay if you have xerostoma, if you have a dry mouth. That can exacerbate dry mouth as well, that can exacerbate tooth decay because saliva washes over your teeth and helps to wash food particles off your teeth. If you're not making a lot of saliva, that makes it harder to keep your teeth clean. This is one of the reasons why they list dry mouth as a side effect on a lot of medications. This is also why they have the slightly weird ads on TV for biotin, the mouthwash, and the toothpaste. That's for if you have a dry mouth, to increase your saliva production so you don't have to deal with issues with your teeth. Your gums, the commanding form for gum is gingivo. If you've heard of gingivitis. Gingivitis occurs when you get inflammation of the gum tissue in between the teeth. Usually you see this in concert with buildup of plaque in between the teeth. If it's left to go for a really long time, this inflammation will lead to breakdown of the bone in between the teeth, and then the bone of the jaw will actually start to recede, and you'll expose the root of the tooth down here. This is bad. The root of the tooth is very sensitive. It's also not protected the same way that the top of your tooth is, so it's more susceptible to developing cavities. By the time you hit this stage right here, periodontitis, you're going to be looking at some pretty serious dental bills and probably surgery to repair and replace the bone tissue and the gum tissue that you lost in between the teeth. Main causes of periodontal disease, probably the most preventable one, is tobacco, either smoking or chewing tobacco. Those will both do a number on your gums and your teeth. Poor oral hygiene as well. Not flossing or brushing. I know none of us like to floss, but do it anyway. If you have issues with xerostoma, again, that will increase your risk of gingivitis. Bad oral health is concerning in more ways than one, more than just worried about like your teeth and your gum health. Like, you should be worried about that. That's important. But poor oral hygiene will also increase your risk of heart disease. We know that the bacteria that's harbored on your gums will increase your risk of having heart attack or other kinds of heart disease. Here's your mouth. You can see in here all of your teeth, the hard and soft palate that you use to help chew up your food and mix it with saliva. This little guy right here dangling down in the back of the throat, this is your uvula. The uvula plays a bit of a role in sound production, but more importantly, this is where your gag reflex is located. When you swallow, the uvula lifts up towards the top of the mouth, and that keeps it from brushing against the food that you're swallowing. But if something was to get forced in your mouth without you swallowing, it would touch the uvula, and that would trigger you to gag and get it out of your mouth. Now, obviously, you can learn how to control and train that gag reflex. That's why you have crazy people on America's Got Talent, like swallowing swords and stuff. I don't recommend that as a hobby. So the pathway from the mouth to the stomach is food goes through the mouth to the pharynx to the esophagus. The esophagus is about 8 inches long from the mouth to the stomach. In the stomach, food gets churned up even further. That helps to break it down mechanically. And then you also see mixing with this enzyme called pepsin, which helps to break down protein, and hydrochloric acid, which is for their chemical digestion. So you see both of those in the stomach. Once food has been completely mixed with those enzymes and acid, and it has been broken down sufficiently, we call it chyme, C-H-Y-M-E. It's a hard CH. And that chyme will pass through the pylorus into the duodenum. If we were to look at a picture of the stomach, kind of a goofy stomach, the pylorus is this little sphincter right here, called the pyloric sphincter. A sphincter is just a little round muscle that opens and closes. The iris in your eyes, the colored part of your eyes, that's a sphincter muscle. And the sphincter, the pyloric sphincter at the bottom of the stomach, controls how much food leaves the stomach into the small intestine at any given time. From the stomach, food will go into the small intestine, into the duodenum first. The duodenum is the first part of the small intestine. It's about 12 inches long. And this is where the vast majority of your digestion occurs. The duodenum is connected very closely to the pancreas, and you will see lots and lots of enzymes from the pancreas that get poured into the duodenum and help to further break down that food into its little molecular components. The middle section of the small intestine is called the jejunum. That's this guy right here. The jejunum is about 6-7 feet long. It's the longest part of the intestines, very, very long. The jejunum serves for mostly absorption. And then the ileum is the very last part of the intestine, also about 7 feet long. And the ileum serves to absorb mostly vitamin B12 and some bile salts as well. So your intestines are your main site of both digestion and absorption. The small intestine does all of this absorption, taking all of your nutrients and putting them into circulation by means of villi, which are these tiny little finger-like projections that you see here sticking out into the lumen of the small intestine. Villi are really, really thin. They're only 1 cell thick, and they have a little vein and an artery and a lymphatic vessel in them. And all of the nutrients that are in the small intestine are going to go from the small intestine across the villus into the blood and the lymphatic vessel. That's how you absorb nutrients out of the intestines. From the small intestines, then, everything's going to cross into the large intestine. The parts of the large intestine are pretty easy to remember. They're named for the direction that they travel through the body. So down at the very beginning of the large intestine, we have the cecum. It's this little couple inches pouch at the base of the intestine. It is mostly there for storage. In some animals, hindgut fermenters like horses, for example, or guinea pigs even, the cecum is where you ferment and break down lots of the grass that that animal eats. In humans, it doesn't have quite that same purpose. From the cecum, then, you have the ascending colon, which goes up on the right side of the abdomen. Ascending means to go up. Then you have the transverse colon, which travels across the abdomen. The descending colon, which goes down on the left side of the abdomen. And then you have this little loop right here. Sigmoid means S-shaped. So the sigmoid colon is the S-shaped part of the colon. And then the rectum, where waste is stored, and then the anus at the bottom right there. You probably saw hanging off of the cecum this little guy right here, the vermiform appendix. Vermi, as you see in vermiform, means worm. So this is the worm-shaped appendix. The appendix is fun. There's a lot of bickering about what the actual function of the appendix is. Some camps that lean to it's a vestigial organ. It serves no purpose. It's just there as a remnant of whatever. Some camps that say, no, it's a reservoir for the good bacteria that hang out in your large intestine, or it's a lymphatic gland that filters the food that enters your large intestine to make sure there's nothing, really dangerous in there. I think most of the research surrounding the purpose of the appendix is leaning more towards it's kind of a reservoir for the good bacteria that you find living in your intestine. Though, to the best of my knowledge, its main function is to blow up at 3 in the morning and send you into the ER. The main purpose of the large intestine is to reabsorb water. You pour a lot of water into the stomach and the small intestines while you're breaking down and digesting your food, and you want that water back. Otherwise, you're going to lose it all in diarrhea and you're going to get very badly dehydrated. So the large intestine is there to absorb water and absorb salts and make sure that we don't lose any more fluid than we need to. And then obviously to form fecal material, which will get stored in the rectum and eliminated through the anus. And for a long time it was thought, that's kind of all that the intestine does. It's just kind of getting rid of waste, your body's trash can, if you will. But we know now there's a whole lot more that's going on in the intestine than just getting rid of waste products. And most of it has to do with your microbiome, the bacteria that live in the large intestine. These guys have become a huge center of research in the last, I would say 5 to 10 years, especially in the last 5 years or so. There are a bunch of bacteria that live in your large intestine, and these are really good bacteria. We like these bacteria. We want them down there because they help to break down some of the food that you can't digest on your own, and they help to produce vitamins from that food that you can't break down. Lots of our B vitamins come from these bacteria. Vitamin K, I think, as well comes from this bacteria. In addition to helping to break down these food products, they also help to keep the large intestine safe. If the large intestine is chock full of all these good healthy bacteria, if a bad bacteria tries to move in and colonize, it's not going to find any room or any space. It won't be able to set up shop, if you will. We know that these bacteria in the large intestine play a role in almost everything. There are links between the bacteria in your intestine and mental health disorders, things like bipolar, schizophrenia. There are certain bacteria in the intestine that show up more in patients with schizophrenia, autism. We know that the bacteria in your intestine affects things like weight, how much you gain weight or how easily you can lose weight. And there's a lot about the bacteria in your intestine that we still don't quite understand. There's some interesting treatments that we use with the bacteria in the large intestine if you wind up having issues with, say, infection in your large intestine. Because let's imagine you have a patient, they are on some kind of antibiotic, and probably you know this from the last time that you took antibiotics. You go to the pharmacy at King Soopers or Walmart or wherever, and you get your little bottle of pills, and probably the pharmacist says to you, so these are antibiotics. These might make your stomach a little upset. You might have a little diarrhea. Take some yogurt with them while you eat them. And the reason because of that is antibiotics kill bacteria, and they're not specific. They'll kill the bacteria that's causing your strep throat or your sinus infection. They will also kill the bacteria that are hanging out in your intestine, breaking down your food and making your B12 and your folic acid. Now, sometimes you'll see in patients who are on very heavy-duty antibiotics, or if they're on antibiotics for a really long time, those antibiotics can start to wipe out the intestinal flora that they have, and that allows other less scrupulous bacteria to grow. And one of the bacteria that you see a lot if you have a patient who is on a lot of heavy-duty antibiotics is called C. diff, Clostridium difficile. Clostridium difficile is normally found in your intestines in small quantities, and you want a little bit of it there. It's when you get very large quantities of Clostridium difficile that you wind up having problems. A patient with a C. diff infection will usually have really, really bad stomach and intestinal cramps. They will usually have really bad, really uncontrollable diarrhea. It's a very unpleasant infection to have. Most C. diff infections, 70% of them, can be cleaned up with another round of antibiotics. The antibiotics will kill off the Clostridium difficile, and then eat lots of yogurt and you should be just fine. You should get your bacteria in your intestine back again. But for that 30% of your patients for whom antibiotics don't work against Clostridium difficile, there's another technique that we can use. And this technique is doing a fecal transplant. Which both is and is not what it sounds like. And I know that sounds horrifying. Usually when I'm in class, my students freak out when I start talking about this. A fecal transplant involves taking the bacteria from a healthy person's intestine and putting it into the intestine of a patient who has a C. diff infection or has some other issue in their large intestine. You do this by taking a stool sample from your healthy donor. You soak it in water because all you want is the bacteria, you don't want the matter. And then either through a nasogastric tube that goes down into your intestines or through an enema that goes up the other way, you introduce that water into the large intestine. And the bacteria in that water will then colonize the large intestine, they'll take over, they'll start growing, and then you'll have nice healthy bacteria in the large intestine. I know it sounds terrifying, but this is a wildly successful treatment for bad intestinal infections that can't be cleared up any other way. One of the studies that I read was of a woman who had had a chronic C. diff infection for 10 years. She had lost so much weight from the diarrhea that she had to be in a wheelchair. She had to wear diapers because she couldn't control the diarrhea. After her first fecal transplant, 24 hours after her first fecal transplant, she had her first normal bowel movement in 10 years. She had a second fecal transplant about 48 hours later and was cured. So this is an incredible technique, taking bacteria from a healthy person and putting it into a sick person. There's some evidence that this may help with things like celiac disease or Crohn's disease. Fecal transplants tend to alleviate the symptoms of those. Even stuff like ulcerative colitis. There's some evidence that suggests maybe those are not caused by just inflammation, but they're caused by a misbalance of the bacteria in the large intestine. So I know this was a very long explanation, but this is a big place where research is going to be very, very big in the next 5 to 10 years, is going to be looking at the microbiome in the intestine and how it affects everything in your body. This is just a quick little overview showing you the whole path of food going from the mouth through the entire intestinal tract. These are some common combining words for the mouth. I'm not going to go over all of them, but just a few that I'll point out. Dento or odonto, both of these refer to the teeth. Both glosso and linguo refer to the tongue. Glosso is Greek, linguo is Latin. This is where we get the idea of a tongue as a language, right? Your mother tongue, for example. In French, it's the same word. Langue is both the same for tongue and language. I think it's the same in Spanish as well. Some roots for the mouth. There are a couple of roots that refer to the mouth, oro and stoma. Both of these are the mouth. And then sial refers to saliva. The rest of these you can look at on your own time. You don't want to listen to me read all of these out. Accessory organs are called accessory organs, not because they're like accessories that you can, choose to use or not use. They're called accessory organs because they are not part of that big tube that runs the length of your body. They're still very important for digestion, and if you don't have them and if they're not functioning properly, it's not going to end well for you. There are 4 accessory organs: your salivary glands, your liver, your gallbladder, and your pancreas. Your salivary glands, you have 3 pairs of these guys. You have parotid salivary glands that sit kind of right in front of and below your ears, near your cheeks, a little behind your cheeks. You have 2 sublingual salivary glands that are underneath your tongue, and then 2 submandibular salivary glands that sit underneath your jaw. If you have ever eaten something really, really sour, like stuck on a lemon or a sour warhead, and your cheeks start to burn and start to hurt, those are your parotid salivary glands that you feel when you're doing that. If you never had that before, go eat a lemon. You'll figure it out really quick. The reason why your cheeks burn when you're eating something that's really sour is because your parotid salivary glands are trying to churn out lots and lots and lots of acid to wash whatever, or trying to churn out lots of saliva to wash the acid that is in the sour thing you're eating off of your teeth. So that burning is your salivary glands filling up with saliva and at the same time squeezing really tightly to get all of that saliva out of your glands. The liver is found on the upper right quadrant of the abdomen. The liver does a whole bunch of stuff. The liver stores sugar to be released when your blood sugar levels are low. Your liver detoxifies the alcohol that you take in. Your liver makes heparin, which is a protein that keeps your blood from clotting. It stores vitamin A, D, E, and K. It does a bunch of stuff. I had a professor in grad school who would always start off talking about the liver by telling us all, always remember that the liver is the most selfless organ in the body, and you should be just as selfless to it. I think he was judging my classmates for their nightly binging, but so be it. But your liver is a very selfless organ in your body. It does a ton for you. When we talk about the digestive system, specifically when we talk about the liver, we're talking about its ability to make bile. Bile is kind of like a soap that you put into your intestine that helps to break down fats. It breaks them down into tiny little pieces so that the enzymes coming from your pancreas can further break those fats down into their respective fatty acids. Now, bile is made in the liver and then stored in the gallbladder that sits underneath the bile. And then when you have something with a lot of fat in it that enters your large intestine, maybe you went to Five Guys and you got the giant cheeseburger, like 4 slices of cheese, and that bag of fries that's just dripping in grease. When all of that fat hits your intestine, the gallbladder will contract, will release a bunch of bile, and that will cause breakdown of all of that fat that's in your intestine. The pancreas is the last of our accessory organs. The pancreas produces a bunch of enzymes that then go into the small intestine, into the duodenum. And these small intestines these enzymes in the small intestine help to further break down all of the food that you take in. So here are 3 of your accessory organs right here. The liver over on the left with the gallbladder sitting right behind it, and then the pancreas right here, and you'll see that they all share this common ductwork that all pours into the the duodenum right there. These are just some combining forms that talk about your accessory organs. If you ever see anything with chole, C-H-O-L or C-H-O-L-E, like we have up here, this is always going to be referring to bile or to gall, and that's what we see in all of these words here. We have the gallbladder, bile duct, common bile duct. These are all referring to stuff associated with bile. Some key terms here, I recommend going back reading through these. There are a lot of root words here that will be very, very helpful as you're working your way through your homework. As you get older, you see changes that happen to the digestive system. Your taste receptors and your smell receptors just lose their oomph. And because smell is such a big part of taste, you start to see loss of appetite. Stuff just doesn't taste as appealing anymore. This is also why Grandma puts a whole ton of salt on her food. Not because she really likes salt, she might, but because she's trying to get some taste, some flavor into that food. Your patients, as they get older, just make less saliva. They have a poorer gag reflex, which means that they have more difficulty swallowing. This might also mean that they're more likely to have issues with aspiration, getting food into the lungs instead of into the stomach. Issues with tooth loss, especially if your patient has not had especially good oral hygiene over the years. And then the digestive organs just slow down, so you don't absorb your nutrients quite as well, and then you don't pass waste product out quite as well either. Everything just slows down. We're going to look at a number of diseases and conditions that you see with the digestive system. Infections of the digestive system are not uncommon. You know that if you've ever spent a night wrapped around a toilet. There are a lot of different things that will infect the digestive system: bacteria, viruses, parasites. We'll look at ulcers, which are not uncommon in the digestive system, especially in the stomach. And that's what we see in this picture up here on the top right. You see these little yellow patches right here. These are all stomach ulcers, where the acid in the stomach has started to eat away at the stomach lining and is exposing the tissue underneath. Usually you'll pick these up on an endoscopy, a gastroscopy, which is what we see right here. They've knocked out our patient and stuck a camera down in his stomach. There are a bunch of things that can cause stomach ulcers. Look at this picture over here. This looks miserable. For a long time, the hypothesis behind stomach ulcers was that ulcers are caused by stress. And you may have heard this before, something similar to it, especially if you read like the older books. There's always some protagonist, oh, my stomach ulcer is acting up. My doctor says I need to spend a month at the seashore to relax. What that we could all get that prescription. This was the hypothesis behind stomach ulcers for a long time too, up until the 80s, actually. People were certain that ulcers were caused by stress and that you needed to relax and have kind of a bland diet in order to heal your stomach ulcers. This all changed, like I said, back in the 80s when a doctor in Australia who was studying the stomach and studying stomach ulcers started to think that maybe there's something else going on here. His name was Dr. Barry Marshall, and he treated mostly stomach ulcer patients and stomach ulcer cases. And at the time, if you had really, really bad stomach ulcers, there wasn't a lot that we could do for you. Either you would just bleed, or if it was really severe, you'd have your stomach removed. This doctor, Dr. Marshall, started to take samples from the stomachs of his patients when they had ulcers, and he started culturing them to see if there was anything in particular growing in the stomachs. And what he found was all of these patients who had stomach ulcers had this really, really high level of a bacteria called Helicobacter pylori, H. pylori, It's a little corkscrew-shaped bacteria that just kind of corkscrews its way into your stomach. That's why you get these nasty lines of infection that you see in this picture here. Dr. Marshall kind of really latched onto this. He thought there was some potential there, but when he started presenting his findings to other colleagues, they kind of laughed at him. Like, there's no way that stomach ulcers are caused by this bacteria. Bacteria can barely even live in the stomach because it's full of acid. So Dr. Marshall decided, well, we need to prove this. We need to have some kind of study that will show that stomach ulcers are caused by H. pylori. The only problem with that is H. pylori only lives in humans. So you can't take a mouse or a beagle or a monkey and give it H. pylori and give it stomach ulcers. That won't work. So his only other option that he had to prove H. pylori causes ulcers was himself. He took a sample of H. pylori, he got himself a little thing of chicken stock, poured the H. pylori in there, and then slammed the little shot of chicken stock, of chicken broth. You could not do that now. That would not fly past an ethics review board, but he was also kind of desperate. His hypothesis was, you know, after a few weeks to months or so, maybe I'll have an ulcer or two. It only took a few days. He woke up with really bad breath, very bad stomach pain, vomiting, and went in and cultured his stomach and found tons and tons of H. pylori. And then he got some antibiotics and killed off the H. pylori and cured himself of his stomach ulcers. And hopefully laughed in the face of all the doctors who sneered at him, and then he won the Nobel Prize. It's a fantastic story. So that is how we discovered that H. pylori is the bacteria behind stomach ulcers. It also can contribute to risk of stomach cancer as well. Now, there is some merit in the idea that stress causes stomach ulcers, just because if you're stressed, that decreases the effectiveness of your immune system. But for the most part, that's not the main contributor. Other things that will cause stomach ulcers, drugs can be a concern about stomach ulcers, especially NSAIDs, or non-steroidal anti-inflammatories. Hopefully you know if you're ever taking Motrin or Tylenol or aspirin, that you should always take that with a full stomach. You should always take it with food, because repeat exposure to NSAIDs will irritate the stomach lining and will increase your risk of developing ulcers. Cancer of the digestive tract is not uncommon, and actually rates of colon cancer are on the rise currently, especially in younger populations. Risk factors for colon cancer, usually bad diet, a diet that is low in fiber, very high in fat, especially like unhealthy fats, like going back to you and your bag o' fries and your giant cheeseburger from Five Guys. If you have colitis, which is a chronic inflammation of the colon, that will increase your risk of cancer. There are some drugs that can be damaging to the colon as well. When you go in to do a colonoscopy, stick the camera up into the colon to check for cancer, what you're looking for are polyps, little growths that are protruding into the lumen of the intestine. Sometimes these are benign, sometimes they won't do anything to you, sometimes they are cancerous. And the goal of a colonoscopy is to remove those polyps, send them off to pathology, and see if they are cancerous or not. Your classic sign of colon cancer is bleeding into the intestine, but usually this is really small trace amounts of blood that you don't see with the naked eye. They call it occult blood. The word occult just means hidden. If you've seen those ads that they have on TV, the little talking colon cancer kit that's sitting in your bathroom, that's what that kit is testing for. You send a sample in and they test and see if you have little trace amounts of blood in your intestine, and if you do, then you go from there. Treatment for colon cancer, depending on how severe it is, may result in removal of some or all of the large intestine. And when you have to remove the large intestine, usually you're going to have to create a stoma, a little opening where you can have a bag to collect waste. The surgery is called an ostomy. There are a lot of stomy, ectomy, ostomy type suffixes. I always told my students you can remember ostomy is just cutting into somebody because you're cutting a hole into that person. So these are just examples of where you might have to put a colostomy bag, depending on how much of the intestine you've removed. Right? If all you had to remove was the rectum and the anus, you might just have a little bag there. Depending on if you had to remove like the whole large intestine, you might have a colostomy bag there. A hernia happens when you get an organ protruding through the muscles of the abdomen. You can see hernias protruding up through the diaphragm, through the muscles of the abdomen, the rectus muscles in the front of the abdomen, or even down protruding through the muscles near the groin. These will usually have to be sewn back together and stick that organ back where it belongs. Pyloric stenosis occurs when the pyloric sphincter is too narrow and not enough food can leave the stomach at one time. And then intussusception is a little hard to explain. It happens when one part of the intestine kind of engulfs the other. I have a picture for that. Here we go. This is intussusception up here. So you can see how this part of the intestine has kind of slid into its neighbor. That will need to be surgically fixed. Volvulus happens when the intestine, or sometimes the stomach even, twists on itself, and after it twists on itself, it starts to fill up with air and become really, really big. You see this sometimes in dogs, especially your dogs that have like a really, really deep kind of barrel chest. Think of like a Great Dane or a hound. The stomach will fill up with gas and flip on itself, and you need to go in and unflip it. Ileus happens when you have lack of peristalsis, so you just have blockage of food in the intestines. And then a hemorrhoid is a varicose vein that you find in the rectum, causes bleeding during defecation, can be very itchy and kind of painful. This is a good example of volvulus. You can see how the intestine is just twisted around on itself. That's not supposed to be like that. That's supposed to go up and over and down. So this patient will need surgery pretty quickly to go in and unloop those intestines. Gastroesophageal reflux disease is also abbreviated GERD, G-E-R-D. This is just kind of a chronic heartburn. This happens when gastric acid travels back up the esophagus from the stomach. Usually this happens to your patient after meals, especially a really big meal, and especially if they eat a meal and then they go lie down. Think about Thanksgiving dinner, right? I just ate until I hated myself and now I'm going to go take a nap. If you have GERD, that will definitely give you some nasty heartburn. A hiatal hernia, which is what occurs when the stomach starts to protrude up through the diaphragm, and being pregnant will definitely increase your issues with reflux as well. Treatment for GERD depends on what's causing it. Weight loss, if that's an issue, sleeping with your head elevated. There are some foods, acidic foods in particular, that can be irritating to the stomach and can increase your risk of reflux. Stuff like tomatoes, lemons, stuff that has acid in it. There are medications that you can take that will decrease the amount of acid that the stomach makes. And then surgery if your patient is dealing with that hiatal hernia and they need to get the stomach back under the diaphragm. Crohn's disease is seen in the small intestine, usually the ileum, which is the last part of the intestine, of the small intestine. This is just a kind of a chronic inflammation of the small intestine. The large intestine version of this is colitis, ulcerative colitis. There is some evidence that Crohn's disease and ulcerative colitis are caused by an imbalance of the bacteria in the intestines, and treating this with a fecal transplant has shown to be kind of promising. Celiac disease is an inability to absorb gluten. Gluten-free is very, very trendy right now, but there are some people who just cannot absorb that protein in their small intestine, and then that leads to inflammation, really bad intestinal pain. Diverticulosis occurs when you get tiny little outpouches in the wall of the intestine. And these little outpouches collect waste product and bacteria, and then after time, they can start to get inflamed and get very, very painful. You usually see this in a patient who has a diet that's very low in fiber. There are some foods that a patient with diverticulosis shouldn't eat. Strawberries, for example, the tiny little seeds on the outside of a strawberry will get stuck in those little pouches and cause exacerbation of the diverticulosis. This is usually treated with medication that will help move food through the intestines. If it's particularly bad diverticulosis, and if it's just in one place in the intestines, you might go in and surgically remove that part of the intestine to give your patient some relief. Ooh, viral hepatitis. Let's talk about some more infectious disease. Viral or hepatitis is inflammation of the liver, and usually when we're talking about hepatitis, we're talking about viral hepatitis. There are at least 6 types of hepatitis. Some are more common than others. The most common is this guy right here, hepatitis A. There are 2 types of hepatitis that are spread 2 different ways. They can be spread either fecal-oral contamination, which is what we see with A and E, or they're spread through blood and other body fluids. And the way to remember that is to remember that the vowels hit the bowels. It's very clever, isn't it? I didn't come up with it. So Hep A and Hep E are our fecal-oral contamination strains of hepatitis. What does fecal-oral mean? That sounds terrifying. Usually I have some student who's like, eating poop. Okay, yes, but you don't do that, hopefully. If you do, please talk to me. Fecal-oral contamination is essentially that, but anytime that you have food or drink that's contaminated with fecal bacteria. Hepatitis replicates in your, hepatitis A and E, replicate in your intestines, is excreted during waste, and then you don't wash your hands and you go, prepare somebody's food and then you give them hepatitis A. That is how it is spread from person to person. Now, we don't see a lot of hepatitis A in the US because we're pretty good at keeping our food and our poop separate. But in other parts of the world where plumbing or waste management may not be so good, hepatitis A is actually very common. There is a vaccine for hepatitis A. You usually don't get it in the US, again, because we don't have a lot of Hep A. But if you were to call up your pharmacist and tell them, hey, I'm going to Zambia in a week, they would probably have you come in and get a Hep A shot. You do occasionally see Hep A outbreaks in the US, usually in terms of restaurant, foodborne outbreaks in a restaurant. And when I was in school, I had a couple of professors who would go around and do investigations for the CDC when you had a foodborne illness outbreak. And they told us that if they ever were called to investigate a hepatitis A outbreak in a restaurant, they always knew that it was going to be this one chain restaurant. Take a minute and think, what chain restaurant might it be that if they had a hepatitis A outbreak was always this restaurant? Usually I tell my students this and they're very disappointed. The restaurant is Taco Bell. They said if they were called to investigate a Hep A outbreak, they knew without a doubt it was going to be a Taco Bell restaurant. So if you like Taco Bell, I'm terribly sorry. Like, you can still eat there, just you'll be fine. You might get Hep A, but you should be okay. But think about what this means then. This means that somebody in the Taco Bell went to the bathroom, wiped their butt, didn't wash their hands or didn't wash their hands well, and is now back there making your chalupa. So, wash your hands. So that's Hep A and Hep E. Those are our fecal-oral transmitted hepatitis. The 2 that are of particular concern in the States are Hep B and Hep C. These are both spread by blood and body fluids. They can be spread sexually. It's kind of rare. Interestingly, baby boomers tend to be at highest risk of undiagnosed hepatitis C, and a lot of that is because we didn't screen donated blood for viruses until the very late 90s. So it's entirely possible if you got a blood transplant in, say, 1975, that you got blood that had hepatitis C or hepatitis B in it, and you didn't know about that. Now, there is a vaccine available for hepatitis B, and if you go work in, say, a big clinic or a big hospital, they will usually offer you that hepatitis B vaccine when you first start working for them. Because if you were to get, say, accidentally poked with a needle, it's much cheaper for them to make sure that you've been vaccinated ahead of time than it is for them to pay for you to be on antivirals for the rest of your life, because there is no cure for Hep B. You will have it for the rest of your life. It can't be cured. Hepatitis C, on the other hand, we have no vaccine. We do have a cure, though. If you have Hep C, there is treatment for it. It is all kinds of expensive, something like $80,000 for a 12-week regimen of curing your hepatitis C. But it is there, so don't get Hep C, otherwise it'll get very expensive. You do tend to see issues with hepatitis. Well, let me back up and reword it. Do any of you remember several years ago, there was a story out of Swedish hospital? There was a surgical tech there who was taking ketamine or some other kind of painkiller out of his patients' bags, their IV bags, and he was reusing the same syringe when he did it, and then injecting it into himself. That's quite often how you see Hep B and Hep C spread around in a hospital type setting. Reusing needles, reusing syringes, reusing scalpels or razor blades. Don't reuse those. They are very cheap. They are easy to get a hold of. If you are ever in a place where you see somebody reusing needles or syringes or something like that, tell somebody, because you don't want them to get Hep C or Hep B or HIV or any other number of things. The surgical tech at Swedish did wind up being HIV positive and I think hepatitis C positive, which is not uncommon in people who inject drugs. So Swedish had to go back and find everybody who had been in contact with him or who had been on the floor when he was working and test them all for hepatitis C and test them all for HIV. Fortunately, nobody came back positive, which is good. But again, don't share needles, don't share razor blades. That's how you wind up spreading stuff like that. Hepatitis D is also bloodborne, but hepatitis D is very opportunistic. You only get Hep D if you have hepatitis B. So you prevent getting hepatitis D by getting shot for hepatitis B. Let's see, we talked about hepatitis E. Hep E is very rare. You find it primarily in Southeast Asia. Actually, the Chinese claim that they have a vaccine for it. Chinese also say a lot of things, so maybe. And then Hep G is another bloodborne infection. This one is pretty rare. We don't see a lot of it. So again, as a reminder, there are only 2 hepatitis vaccines available, one for A, one for B. If you get C, you will go bankrupt trying to cure yourself. So don't share needles. I have spoken. The real concern behind hepatitis is that if you leave it untreated, you can eventually develop cirrhosis, which is chronic scarring of the liver. You see it a lot with just this excess consumption of alcohol. That will do a number on your liver. Right? This is your liver. This is your liver on alcohol. With cirrhosis, you see hepatomegaly. The liver will start to get pretty enlarged as it starts to develop all this scar tissue. You'll see edema and ascites. Ascites is buildup of fluid in the abdomen. The abdomen will look really big and distended. And then you'll see jaundice as well. Your patient will start to turn yellow. Once you get to like this stage down here, you're kind of toast. You need a new liver. If you catch cirrhosis early enough, you can stop the damage. You can't reverse it. What has been done has been done, but you can stop it from progressing any further. Gallstones are found in the gallbladder, usually in concert with cholecystitis, which is inflammation of the gallbladder. Cholelithiasis refers to stones in the gallbladder. Our combining form litho means stone or rock. Usually this is because the gallbladder is not emptying all the way and you have bile retained in the gallbladder. You can diagnose this a few ways by an ultrasound or an X-ray. Treatment will vary. There are medications that you can use to dissolve the stones in the gallbladder. You see all of these stones right here. You can also do shock waves and ultrasound across the gallbladder that will help to break down those rocks. But if they are really big and if the gallbladder is really badly infected, you may just have to go in and do a cholecystectomy where you remove the gallbladder because your chances of having stones in there again are pretty good. Pancreatitis is inflammation of the pancreas. There are a lot of things that can cause this. You see it a lot with like long-term chronic alcohol abuse. You see pancreatitis. There are drugs that can affect the pancreas as well, infections. Usually you only get relief of pancreatitis once you take care of the symptoms going on, once you start supplementing enzymes for the pancreas so it doesn't have to work so hard. The issue with pancreatitis is that it increases your risk of pancreatic cancer, which is pretty rare, but it is also pretty lethal because usually you don't have any symptoms until you're at the very end stages of pancreatic cancer. This is the cancer that Alex Trebek, our game show host on Jeopardy, that he has, and actually has been alive for a year after the diagnosis, which is pretty darn good for pancreatic cancer. Signs that you'll see of pancreatic cancer: jaundice, sudden unexplained weight loss. I'm not exercising, I haven't changed my diet, but all of a sudden I've dropped 20 pounds. Sudden diabetes, when you've never had like any issues with diabetes before. And then sometimes pain in the upper abdomen and the back. And actually Alex Trebek in one of his interviews talked about how he had some pretty chronic stomach pain for a while that he never went and got checked out because he just didn't think anything of it. Causes of pancreatic cancer: if you have chronic pancreatitis, you're constantly dealing with inflammation of the pancreas, that's a big one. It can run in the family. Smoking is a huge contributor to it, poor diet and lifestyle as well. Kind of our unholy trinity of pancreatic cancer is smoking, long-standing diabetes, especially if you haven't controlled it well, and poor diet. Those three will contribute to cancer of the pancreas. Long-term outcomes for pancreatic cancer are really, really bad. Only 1 out of 5 patients lives to make it a year past their diagnosis. Only 7% of your patients will be alive 5 years later. And the reason for that is because, again, you don't usually catch pancreatic cancer until it's very advanced, and there's not a lot you can do in the way of treating it. It's not like the stomach that you can just remove, and you can't really transplant the pancreas. The pancreas doesn't do well leaving the body and going somewhere else. It likes to stay in its original home. It's not like the kidneys or the liver. So some key terms here for you to read over. These will be very helpful for your homework and for studying for the quiz. And as always, thank you for joining me. If you have any questions or if you would like to go over any of our topics in further detail, feel free to drop by during office hours. I would love to see you.